Hello, everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at the Advisory Board. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Please join us after the webinar for a holiday cocktail demonstration by the Lush Life's Sarah Tracy. And with that, I will turn it over to our speaker who joins us from the Advisory Board, Ken Leonchek.
All righty. Hello, everyone. And I'm hoping very much everyone can see my screen and that this is working well for us. I know you can't see me very well with the camera, but I'll come in and say hi, and you can see my picture on the screen right now, I hope. I'm Ken Leonchek with the Advisory Board, and I'm excited about having this conversation with you today about the state of the health plan industry. Before I dive in, I just want to briefly tell you who we are. If you don't know us well, we're an independent research firm as part of the Optum United Health Group family. And we help healthcare leaders in the industry work smarter and faster by providing provocative insights and actionable strategies, as well as practical tools, all to support your execution. So we're health plan experts, but we're not just health plan experts. We're healthcare experts. For over 40 years, we've worked across the full ecosystem in healthcare, particularly on improving those intersections in healthcare, where plans and providers and members or consumers, patients, all come together. So if you're interested in learning more about us, you can let me know. I've got my email on that last page, and at the end, I'll give another email that you can send to us as well. Questions you can put into the chat. I'm hoping to have some time to hit those questions, and then if not, we can get back to you, and you can also email me directly as well. So that's my little intro. As I said, I really am excited about this topic and talking about what plans are doing from a strategic perspective and what health plan executives across the country are telling us that you are grappling with. I think this year more than any other, we're going to be talking about the ways that our fate is intertwined with others across the broader healthcare industry. I mean, it's an absolute understatement to say that the last almost 2 years, coming up on 2 years now, have been life-changing, because they have. But what I'm going to cover today are actually the key inflection points that I think will show the way that it is next year that's actually going to determine the future course of this industry and what it means for health plans. So let's start off by recognizing that there are hundreds of decisions that you all and your counterparts across different sectors of the healthcare industry are making right now that will have profound implications for the future. And as long as those questions are unanswered, there's no way that the future is set. So I would posit to you that the question you really should be asking yourself is, what do you want the future to be? The good news is that we already know what the major points of inflection will be. You can see them across the bottom of the screen there. I mean, those are the things that have the potential to play out in ways that are directionally different, not just incrementally different. And look, there's a limited time window. Your opportunity window isn't that big. This is this time window where you can shape the trajectory of these shifts. Decisions are being made now that will have profound implications on these things that you can all meaningfully inflect. Where we land, it's going to have consequences across the entire sector, and it's going to determine the relationships between winners and losers in the healthcare sector. So look, the implications themselves, they're incredibly significant. We're talking about the opportunity to shape the future, value-based care, the future of home-based care. These are big things, but beyond that, I also think the decisions we're making today that we're going to talk about really have the potential to move the needle on some of the larger tensions that we've been grappling with in the industry for a long time now. Things like the structure, of the healthcare delivery system itself. It's not the first time any of us have talked about these issues. There's nothing on the bottom of that page that's new, but this is a time where there is so much up in the air that you have the ability to influence. So what I want you to keep in mind as we talk about these inflection points is the fact that the balance of power within and across these sectors is shifting. And I think to understand the true state of our industry, it requires us to dig a layer below what you'd see in flashy headlines or medians or margins. Because if you just looked at them by themselves, you'd see something along the lines of, even if you take into consideration all the recent shifts in health system capacity with the pandemic raging, cases swimming up in some areas, you look at everything that we know, aggregate demand is unlikely to change significantly. The overall uninsured rate really has only seen minor increases, and all of the segments of the industry are on the path to financial recovery. Right now, none of the big purchasers are talking about making big cuts. Yeah, that's true. Superficially, that is all true, but that is a wildly inaccurate assessment of the industry itself. Because aggregate demand, sure, it's not going to shift significantly, but demand for individual service lines, it will. Demand for individual sites of care, that absolutely will. And sure, the uninsurance rate, it's only like gone up by about 1%, but overall Medicaid coverage, it's gone up about 10%. That's huge, all-time high, record Medicaid enrollment. And we're going to see even bigger swings, I think, once the PHE, the public health emergency, has ended. So most importantly, I would say to you that while the averages across all sectors have stabilized, what the pandemic has done is it has widened the gap between the industry's haves and the industry's have-nots. And that's why we need to take a close roll at what our future will be and how we can shape that future. But before we do that, I actually want to do a little bit of a look into the past, a bit of a history lesson almost. So what you see here on the screen right now is a photo of Churchill and Roosevelt and Stalin, and they're at the Yalta Conference in 1945. It was the second meeting between the US, UK, and Soviet Union to discuss the post-war reorganization of Europe. This is the point in the war where everyone knew how it was going to end. It wasn't quite over yet, but they did know who was going to win. But what they didn't know is how are things going to be rebuilt? Where's going to be a democracy? Where's not? Who's going to be politically ascendant? Who's not? Back then, the folks at home were crying for a return to normalcy. They just wanted to get back to how things were. I think we're hearing that a lot in the U.S., across the world right now, to get back to normal. But these folks here, they realized that they needed to make decisions there that would have an impact on what the new world would look like, the new world order. I don't know if they knew how big these decisions were going to be when you talk about geopolitically and the lines of Europe being drawn, the lines of the world, but they did know that the return to normal wasn't available. So what I'm saying to you, and I think you get the metaphor here. I don't need to belabor it. You can decide who you want to be in that photo. But what I'm saying to you is here we are, and the end of 2021, and we're fighting a different war. But we need to look at what's going to come next, because last year shook up a lot. It didn't resolve all that much, but the balance of power has shifted. Assumptions have been shifted. Some people are in much greater, some organizations, much greater position of stress right now, which means that different powers are in ascendant, which all leads to the two big points I want you to hear from this. One, you have agency. You have the ability to make decisions and engineer the healthcare world to be what you want it to be. And the second is your agency, just like these leaders here, is relative to all of the others. And while the balance of power is shifting and the decisions you're making will impact others, I want you to be aware of that. So there's our little insight for you. You can certainly read this on your own. We're going to send you this whole deck. I'll just say don't underestimate how important this period of time is to be able to create healthcare, create it into what we want it to be. So here's how I want to spend the rest of our time together. I'm going to start out with a discussion of the status quo, of where do things stand right now in the health plan space, particularly in relation to the rest of the industry. And I'm going to talk about some of the most interesting strategic moves that I've seen across the last year in the health plan space. And then we're going to dive into those inflection points that I showed you to give you a better understanding of what things could like in the future and what health plans can do and are doing to be able to influence as things play out in the future. Again, feel free to put those things into the Q&A, and likely we'll have some time at the end for them. And if not, certainly we'll get back to you. So what you see on the screen right now is an enormous amount of text. You can read through it all and follow up. I want to give you a snapshot view of how the health plan sector is doing at a high level. 3 main points. On the expense side, we're back to uncertainty. Payers and purchasers are all exploring more of the hedging postures that we had seen about a year ago. If we were talking, I don't know, 6 months ago, 7 months ago, I think I might have, we as an organization even might have had the hubris to say, let's do some post-COVID projections. We're back into uncertainty. Surges are coming back, electives delayed in some places. You've all seen the headlines, the Omicron uncertainty. I mean, I often look to the UK as what's happening there to see what's happening next, and it's there's a lot going on right now. Where I feel more certain, and as an organization we feel more certain, where we see more clarity at least, is on the demand side. What we have seen are coverage shifts that seem to favor national and large regional non-blue plans in the long run with Medicaid and Medicare Advantage. What we've also seen is confusion when it comes from employers on how to prepare for future healthcare costs in a time right now where the importance of benefits is so high, and when the options for solutions here are so varied. I mean, they're getting bombarded with options here. Finally, if you blur it all together, what we're seeing is that the landscape of health plan strategies are changing in ways that aren't necessarily dependent on scale. And there are some common themes in the way that we're seeing these strategies play themselves out, but they're definitely varied means of execution. Everything from integration to diversification. I'll go into more detail into this, all of these actually, in this first section. But overall, when predictions are uncertain and when purchasers are confused, when structures are changing, what this boils down to, and the conversations I'm having with health plan executives are all around this, what it boils down to is real fundamental questions about the identity of a health plan. What does it mean to be a health plan in 2021 moving into 2022? So let's take a look at the things that I said I'd look at in more detail, starting with expenses. I first have to show, we're not out of the woods yet in this pandemic. Delta, Omicron, the front lines we're back on them. You can see most recent data that I pulled for you. Hospitalizations are up, but it's not all bad news. Vaccination rates are up right now. Lots of uncertainty there. Beyond these rates that you see, the data there at the bottom of the screen themselves, I've heard from many health plan leaders that there's just so much noise that they're seeing in the data, and they're really looking for an understanding of the relationship between utilization and intensity and acuity of services, particularly from the worsened conditions that came because of COVID, particularly COVID delays, screenings, and whatnot, and the impacts of long COVID. Some people are calling them the long haulers. There's just a lot of desire to see more in that, and we're looking for it. So if you look more closely at particular services, I think there are interesting peaks and valleys that we're seeing in that regard. But the point of that is there's just a lot more to be determined. Of course, volume, look, it's only one part of cost. So I do want to note that flying under the radar right now, and I don't think I have, flying under the radar right now is an uptick in pricing for commercial cases. This might turn out to be inflation in healthcare prices. It could be sticky for the long term. I note it for you because it's something we're watching particularly carefully. Where we are very confident about the impact that the pandemic is having, and where I feel very strongly about this, that we are going to see a permanent impact on where patients access care in the future. The clearest leading indicator on this front is ED, emergency department volumes. While everything else has been coming back, they're still continuing to lag. Now, of course, this trend certainly extends far beyond the ED. There are a whole host of services, electives, diagnostics, basic primary care visits. These are all things that could shift as well. The perspective I want to give you right now is that the magnitude of this change is largely unwritten. In conversations that I have had, mostly with health plan leaders here, but very much with health system leaders too, is they tend to think about site of care shifts as something that happens to the industry. It is a force that comes from outside and is imparted into the industry. But I think if we've definitely learned this in the pandemic, that consumer preference and behavior is very flexible. And I think the most important lesson I would give you here is that plans are especially ones pushing a lot of the shifts here and can and should be the ones pushing the sites of care shift moving forward. All right, let's look at revenues for a second. A lot going on this. The pandemic did a number on commercial coverage, and we're still getting in new data each quarter. So really, a lot of it depends on when you want to start count. So if you go back to the beginning of 2020 into spring 2021, there were 14 million fewer people who were commercially insured, but many of them fell into safety nets. Largely, they fell into Medicaid. This was probably the first real test of the ACA's insurance safety net, and I think it probably mostly seems to have worked. You know, the uninsured rate really only increased by about a percentage point. Some of it came from the exchanges, and Biden administration absolutely is investing heavily in that, but most of the growth came from Medicaid. Medicaid today is larger than Medicaid has ever been. I mean, overall, managed Medicaid grew about 20% during the pandemic. So I think it's worth taking a closer look at what happened across the types of plans. So what you see here on the screen right now are the absolute shifts in enrollment from 2018 to 2020 from the nationals, the blues, and the large regionals. And it's broken out by business line. We've got commercial, that includes ASO, group, individual. We've got Medicaid managed care, and then we've got Medicare Advantage. So there are a couple of things that I want you to notice here. First and foremost, the biggest movement happened across the nationals. Their employer-sponsored insurance dropped the most, but they also benefited the most from the influx into Medicaid. Now, relatedly, the nationals continued their dramatic growth into MA, Medicare Advantage. Look, the pattern had obviously been going on pre-pandemic, but I think it is very notable that it did not slow during the pandemic. And that's, you know, one of the biggest reasons that there's a difference in how the nationals' overall enrollment and their overall portfolio looks as more durable when you compare it to the Blues plan. Blues overall are much more spread out in their financial performance. Some of them, a number of them, frankly, have dipped into concerning negative margins. Moving forward, look, it doesn't mean that national plans will dramatically swing to be mostly government enrollment, but it does mean that they are increasingly eyeing public growth as a strategy. And as we look ahead to coverage expansion, I think we need to always keep in mind where that shift will go, whose power is ascendant. To sort of zone in on Medicaid for a moment, the reason for growth in Medicaid enrollment is twofold. Many individuals became newly eligible for Medicaid because they experienced, loss of income or decline in income or loss of job or significant decline in, well, loss of job. But look, there's another important factor here. I think this is the more important factor. States have been prohibited from disenrolling people from Medicaid during the duration of the public health emergency. Most of the MCOs I talked to really think this suspension and disenrollment was the biggest factor in the growing size of the Medicaid population, bigger than the influx of newly eligible enrollees. As you probably know, the Biden administration has told the states, look, you got 6 months. We're going to give you 6 months of warning before we end the PHE. So as of now, it's expected to remain into effect, but it's a very big open question of what might happen to Medicaid enrollment once that PHE ends, once states can resume their typical eligibility checks, their typical disenrollment activities. That's one of the big things they do. That's one of the big lobbying that's being done by Medicaid trade groups, community plans, and health plans involved in that area around the disenrollment process. So the big open question here is, this is obviously Medicaid's a state level issue, but how each state goes about the disenrollment process, what timeline, it's very much going to be up to them. It's pretty interesting because right now most states have seemed to want to be generous in the Medicaid space. I have a hard time seeing how that continues when you look at the budget, the hard economic realities, but watching this space carefully because we could see that cliff definitely occur. Beyond current eligibility, like any coverage expansion, I think is going to happen at the state level. There's an ongoing conversation about the expansion of the safety net, but I don't see any political will for Medicare for All. More momentum for Medicaid expansion. The American Rescue Plan had some significant financial incentives for states around Medicaid expansion. You probably saw the hubbub right now, or legitimate around looking at changing disproportionate share payments, dish payments in non-expansion states. So there's conversation around this, but the sort of like most real place where we could see a big change, and again, like I'm not saying it's going to happen, but it's the state level public option experiments. They do seem to be gaining traction at the state level, especially when it's about getting the least privileged residents more access to care. I do want you to keep in mind, though, that the proposals for state level public options vary significantly. Many of them continue to rely heavily on the private insurance market and the private plans. I personally think a lot of these proposals aren't, I don't think it's fair to consider it a public option because it's so run by the private industry. That's neither here nor there. What is definitely here and there is that these proposals have attracted significant pushback from both providers and plans. And in at least one state in Washington, they went and watered down their approach as there was a real pushback during the pandemic. So look, I talked about Medicaid, a little bit of coverage expansion, which is probably going to be mostly Medicaid if it happens, and there's gotten a lot of attention in those areas, as it should have during the pandemic. But there is a under the radar trend that I really want you to look at, and that's that Medicare Advantage. Lots of plans. Almost everyone I talk to, big and small, sees opportunity in this growing market. They've seen that opportunity for the last several years. And on the surface, it certainly seems like a golden goose. There's a natural growth from the demographics, and if you can continue a relationship with a beneficiary, after retirement, there's just great opportunities here. The question is it a golden goose, or is all that glitters, not gold? Because here's the deal: we've got both enrollment and per capita spending on the rise, which means that MA is becoming a larger and larger target for overall Medicare cost cutting. Our HHS secretary, has given general support for the program, but he's also raised significant concerns about the disproportionate share of Medicare spending that is going into Medicare Advantage. And as Medicare in general creeps towards insolvency, M&A becomes Medicare Advantage, I think, is going to become a larger and larger target because it's getting a larger and larger share of that overall Medicare budget, which means that the federal government has to look at it as a source of savings. And a lot of things could be on the table. And some of them, varying levels of support and varying levels of impact. Some very impactful for these. So if it's aggressive cost savings that the government goes for, and I think it's pretty interesting to see just how aggressive the language is around the need to save money in Medicare Advantage. Well, we could see the federal government, outright lowering plan payments or changing benchmarking to be more competitive against MA plans rather than against local fee-for-service rates. We could also see changes in risk scoring methods. That's one of the main enablers for financial success in Medicare Advantage. It's where a lot of the attention goes. Good amount of attention coming from the DOJ in that. Right now, we could even see questioning of the STAR bonuses program. That's not budget neutral, y'all. And we've already seen some changes in the works there with a weighting emphasis on patient experience when you look at future ratings. So all of this to say that I think plans need to proceed carefully in this growth hotbed because so much of a plan's infrastructure investment, so much of a plan's strategy, so much of a plan's opportunity for profit in this segment relies heavily on optimizing for risk coding and star rating policies. I still think it's a great area. I am saying to you, we believe that MA, Medicare Advantage, is going to grow. The question is, will it always grow from a reimbursement perspective? The other reality is this is a very crowded space. So last part of the demand profile that I want to cover is the employer-sponsored space. And I want to give a little bit of a history here. We have had lots of toolboxes for controlling costs while keeping a attractive benefit in this space. And I think we've gone through all of them in the last decade or so. Managed care and then cost shifting, thousands of dollars of deductibles. People don't like them. I think we all know that. I don't think they're going anywhere either, but there's only so much, there's no more juice, honestly, to squeeze out of that cost shift area. So the question is, what's next? The perennial balancing act for employers is maximizing savings on one hand while keeping employees happy with their benefit on the other. And right now, employers are more cognizant than ever about the perceived value of health benefits. We are in record labor market right now. And in normal times, a tight labor market means benefits are even more important. But we've got wage pressure. And that's creating a lot of confusion for employers, especially employers who are seeing such wage pressure on the lower end of the wage spectrum. So you can't cut benefits, but you got more pressure on wages, then you need to find a way for savings that doesn't upset the individuals themselves. I will tell you right now, employers, they're open to anything. I mean, I had a health plan CEO say to me, employers are coming to us, look, if we're paying $1 now, I need you to get it down to 85 cents. I don't care how you do it. So they're open to many ways. They're looking at many different ways. And one of the ones that they're looking at is finding ways to manage drug spending. I would say this is increasingly popular. Frankly, I haven't talked to an employer who hasn't mentioned this as something that they care about, and just kind of common sense says that the average employee would likely support this as well. The problem here is twofold. The first is it's just a very complex space. And employers are just in the very beginning of this. They don't even really understand fully, or a lot of them don't, understand how the pharmaceutical value chain works or where the main opportunities to inflect spending actually are. The reality also is that with all of the attention on drug prices of recent years, for most employers, their drug spending is going to be relatively small potatoes compared to medical spending. So what we at Advisory Board think is that the most likely focus areas for the coming years are going to be definitely on the top of this graphic that you see here, but very much around steerage. It's going to be all about steerage. There are lots of stories that we're seeing around soft steerage, broad networks, but with incentives in place that will direct you in a certain way. Broad networks, but I'm going to do what you want me to do. Look, those are good. They've got real potential for real cost savings without those hard restrictions on choice that the average employee is not a fan of. But there are some real challenges with that as well, because employers really are walking a bit of a tightrope. They can't call their own shots in healthcare finance. They just don't have the market power when you compare them with providers to be able to successfully negotiate all on their own. And increasingly, they're getting bombarded with a host of sales pitches about point solutions here. Some of them may be great, some of them may be pretty terrible, but there's too many. The employers can't sort them out. So who brings order into this chaos? I think it certainly could be the role of a health plan. But this could also be an area where you're getting disintermediated, where the employers and or the providers are looking to temper the power of plans further, and that they could end up looking towards each other for strength. All of this leads to how are health plans approaching their own strategic design. How they configure themselves and their products will have bearing on whether they can meet the growing needs of their purchasers, especially these struggling, overwhelmed employers, and whether they can do so without adding additional burden, additional difficulty. And also, like, the decisions that are made here are going to decide for the future whether you're set up to continue to grow in the government space, which, as we've spoken about, is increasingly attractive for plans. So a couple areas I just want to highlight here. The first is around the horizontal action. Across the last year, of course, we've seen a lot of M&A, mergers and acquisitions playing out. Some new regional powerhouses have been formed. You've got larger players that are growing scale. I think we've also seen a potential shift in how we see Blues, as they're competing with each other and growing their own size. Interestingly, we've also seen payers hold hands with other payers on joint ventures, on experiments. Some of these are to test out strategies. Some are to complement their own weaknesses, and some of them are to tackle the more thorny structural challenges like outcomes-based contracting for drugs. So interesting action here. And the area I now want to sort of call out within that is the moves that the large nationals are making, because they have a lot of fingers and a lot of pies. Look at this table here. The only line on this table in healthcare that's not there is the hospital space. I think it's very clear what the large nationals are building. It's not a payvider. I actually want to get rid of that term. It's a health system. That's what they're building, a health system, an integrated delivery network that has everything except for a hospital. Home care, pharmacy, PBM, virtual. It's just not enough now for these large nationals to want to just steer their members to lower cost points of care. They also want to control the forces that are driving the steering. And they want to control many of the places that they're being steered to. I don't think it's totally brand new news. I think you all probably recognize this, but they're all building this, but they're not building the same thing. they're going about it in a different way. So while all of the big national plans have a clear focus on M&A, I just think it's a mistake to think they all have the same strategy, because there's really a lot of variability in what their approach is. So again, I'm going to do the horizontal axis, vertical axis, and describing this to you. On one hand, if you look at the horizontal axis, that shows consolidation with respect to business segments. And you've got players like UHG who seems to me to be setting themselves up as a hedge to do well regardless of what happens in the world. Whichever way the industry goes, they're going to be there. They're leaning towards significant diversification across business models to a foothold across many market segments. And then you got Cigna, you got Centene. They're focusing in on a segment. On the vertical axis, is the question, what's being done with all these assets that are being put together? Are these hedge plays? Is this diversification for diversification's sake? Or is there a sense of synergy? Do the pieces fit together to create something more? That's what Humana is increasingly aiming to do. They're aiming to build around that M&A or that MA, Medicare Advantage, and home space. So I just want to give a couple of caveats with this. First and foremost, this is all relative to each other. There's still a lot of similarities between or across the large nationals, and there are still many ways that they're way more similar to each other than they are to smaller plans. The other thing I want to say is there's no sort of section or place on this graphic that I think is more or less innately advantaged. There are ways to win in all of these quadrants. The other is there are going to be other reasons for why plans have assembled what they've assembled, built what they've built. Financial rules across MLR might be one of them. But I think we're pivoting to a stage now where plans are recognizing that they want to move towards common purpose. And I think it's important to recognize where these plans are heading. And that's what those arrows are. That's what they represent, where they're trending over time. And I think in many respects, this comes back to this fundamental question that I'm having conversations around that I'm most interested in is, what is the identity of a health plan? What is there? What does it mean to be a health plan? We're starting to see all the retail pharmacy chains offering behavioral health services, regardless of insurance affiliation. CVS, they're one of them. Optum, they're doing direct-to-consumer sale of drugs. So, how far do we think things are going to head in that direction? Because in many senses, I think this is a real departure from an insurance strategy. So as we watch these, I think the question really remains, what's the limit to which the insurance business defines what a whole company is all about? I mean, are these even health insurance companies anymore? What is it a health plan or is it a health services company? Because honestly, even thinking that, for the bigs, it's not just them. There's an increasing number of ways that plans can diversify. I mean, the smaller disruptor plans, they're really starting to ask them, new plans starting to ask themselves, what do we sell? Who am I? What am I? It's like the children's book to a certain extent. I mean, we've got these smaller plans increasingly looking to investment dollars and technology as a growth strategy instead of looking to covered lives. The insurtech disruptor plans in particular are very interesting to me because they're starting to say our secret sauce, is the tech. And we'll sell you the tech. Oscar and Collective, they're both putting their tech platform on the market as a service or purchase. Got to prove what's worth being paid for and whatnot. But I think what's really fascinating in this is that even young plans are already thinking we need to be more than what would be traditionally considered a plan alone. And this notion of maybe I should be more than what was my core identity, this is happening in big tech as well. The tech space is, with every year, aggressively and chaotically, to be very candid, looking at all the opportunities to get in and fill the gaps in healthcare, or even get in areas that are already gaps we would think are already filled. They're looking at getting into the provision of care outright as one example there. They're looking at ways to commodify, to disrupt payers, and to commodify and disrupt providers as well. Yeah, it's fraught. It's risky. I mean, look at Haven's collapse. Google shuttering of the centralized health division. I don't even know what to do with that, right? But what I can tell you is that this right here is certainly a corner of the economy that has as much a claim to being a cohesive platform for member interaction as providers or payers do, which means we got to watch them and we're going to have to work with them. What big tech is doing could be equal parts antagonist, disruption, or partner, and or all of the above to payers. And there's enough money here. You got to be interested in what the solution is. You can't cast them aside, but you certainly also need to be on your guard and open to collaboration. I was talking to an executive recently. Actually, it was a couple months ago, and I was trying to think of, what do we call them? Do we consider them counterparties? What do we call this big? And he said, you got to call them frenemies. And I think that's the best phrase I've heard and description for this. Big tech is our frenemy. We're going to have to partner with them. There's great opportunities, but be careful what you're sharing. The other thing I just want you to remind you of here, as we're talking about big tech, is that there are a lot of requirements, regulations that they don't have that traditional healthcare players don't face. They're a lot nimbler, way nimbler than traditional healthcare players, particularly plans. But most, or at least much, of the savings that can earn a profit in healthcare is anchored in avoiding unnecessary high-cost treatments or in managing ongoing chronic conditions. So the opportunity for us as plans to partner and connect mechanisms with savings with these new ways of earning consumer attention, those vast, and that's the place to play here. Another executive said, look, all companies in healthcare can't be all things to all people. Yeah, that's exactly what we're talking about. So that was my whirlwind tour of where we stand right now from a strategic business perspective, which brings me again to the inflection points, which I intend to run through with you quickly. Hopefully give you a taste of this, and then if you want more, you can certainly come back to us at Advisory Board, to me as well. You've got our info here. I want to dive in first with value-based care and alternative payments, because going back to that Yalta metaphor I gave you at the beginning, we're not trying to recover from the war. We need to be thinking about building a new structure for how we operate in the future. So what you see here is a fork ahead that we've created of where we think things could wind up. So on the one hand, there's the possibility that we'll achieve the idealized value-based landscape where we as an industry move away from fee-for-service into a world where providers are operating their businesses under a fundamentally different incentive structure, where care models are adapted and fit into that purpose in a near universal way, real population health, if you will. There's also a real possibility, and maybe it's even fair to say a bigger threat, that the future of value-based care will simply be a physician compensation model. This is a world of more targeted risk models instead of full-blown population health risk. And if we don't see payers and health systems working through the very real tensions that they have, then I think we're going to see plans go with this physician compensation only model. So I don't think the really issue is whether we're going to see more risk or not. I think we're going to see more risk. I think the issue and the question for the industry is it a reimbursement standard that is there for the entire industry, or is it something that's just focused in the physician space alone? So what are the signs we should be looking at for how this will shift? Well, CMS, as always, I think is a bellwether here for the industry. And, if you look at again, history here, there was this sense of inevitability in the provider community that you're going to have to shift into more risk. And then that started to erode. Providers just didn't have to push CMS very hard to stay in the upside. Upside only, in my opinion, is not risk. Risk requires the possibility, inherent in the word itself, for it to have a definition. It has to have the possibility for loss. There has to be risk. So Medicare took its foot off the gas. It was all about participation, not about outcomes. But now, we're looking at performance. We're looking at outcomes, and CMMI has recently said, if that's where their focus is going to be moving forward. So for this section, I leave you these strategic questions to think about. We'll be watching CMS, and you can stay tuned with us and all of our materials that we put out through advisory.com as well in our daily briefing to see where they're going. Next fork in the road is physician alignment. I just told you that the very real future could be value-based care, simply a physician compensation model. I think a lot of that first question also goes hand in hand with where physicians end up from a structural perspective. So let's take a look at that, starting with the fork in the road that we see. And here the fork is one of power. There are a whole lot of doctors employed by hospitals, but more and more physicians are choosing to go it alone, not join a hospital, but instead align with an array of other types of partners, or truly go by themselves. Look, this is about a lot more than about where physicians hang their hats. This is ultimately about how much hospitals are able to solidify themselves as the locus of control, as the segment of the market through which all else flows, versus a world in which hospitals are essentially commodities who have to work to attract referrals from non-aligned physicians who will have very different financial incentives from their own. And it's a really big issue out here right now where physicians have no shortage of non-hospital partners to work with. Private equity had a record year in fundraising activity, and healthcare is a top 3 priority. If you look at 2020, obviously that was a little bit of a quiet year in deal making, but we've seen some real surges this year. And we've seen a significant growth in what we're calling non-traditional independent groups. Historically, we've talked about these folks, you can see them on the screen. We've historically called them startups. They're not startups. You just can't, several of them are public. A lot of them are like massive valuations. They've seen outsized growth during the pandemic. They didn't just survive. To a number, many of them flourished, and in our own health plan sector, we've been working to deepen our foothold in the care delivery space. If you think back to that slide I gave you earlier, which showed the health plan, big nationals trying to be a health system, this is an area where you've seen a significant amount of movement. So again, some strategic questions for you to think about as we move forward. I want to give you a little taste of home-based care and virtual care, and then we'll see if we'll do questions, or maybe I'll hit the others, depending on time. If you look at the evolving set of options for care, one of the things that, if you think about sites and modalities, one of the things that comes to mind very much is home-based care. And the concept of care in the home is not new, but in the wake or the midst, I would maybe say, of the pandemic, we've seen stakeholders of all types making very big bets on home-based care. Policymakers have shown a clear interest here. The industry, I've been talking about home-based care for at least 10 years, 15 years, and people have been doing it before it. The question of feasibility has been what has lingered. Does it make financial sense for the different segments? Are patients going to use it? Will providers trust it? Will the regulations and reimbursement shift enough to make this a reality? I think the reason the industry is moving full steam ahead is pretty obvious. The pandemic really did remove a lot of the barriers that have been slowing us down, and patients are way more interested, or at least were, in getting care in the home. Clinicians are getting way more comfortable with this. I think the big overarching roadblock that could limit the industry's success, despite the best of our efforts here, all comes down to whether we can figure out and secure a sustainable funding model for these efforts. It's not a novel point I'm giving you here. We all have seen great ideas come and go because the industry made investments in short-term pilots or in one-offs, but there was no sustainable funding model for it. One-off government grants were all we got. Or maybe you've even seen a standalone vendor that was very successful, but it didn't make its way into the mainstream. So moving past this is going to be the difference between home care being a flash in the pan or a long-term permanent shift. It will require long-term shifts in policy to broaden reimbursement. It will require plans to increase coverage, providers to position home-based care as something, akin to one of its own service lines with its dedicated budgets. Those are the things that I think will be needed for the industry to move here. We're seeing some movements around reimbursement. This is something that we're going to be looking at closely. I do think, we're seeing, this is one of the sites of care shifts we are seeing is the shift to home, but what will its influence on the industry be here? Well, the first one is the non-starter, that all the funding goes away or people are tired of being in the home. That's a possibility. And we got to get past that funding and actually figure out how it's going to be sustainable. You get past that little stop sign question mark. There's 2 ways that it could go. One is this could just make things honestly worse for the industry, because you're going to have some organizations that are just really pushing it, and it's only for the haves. I think we'll haves nots. Like, will this make health equity more of a problem? Will this hurt disadvantaged people even more? Will this make it more difficult to serve rural and or urban areas, depending on what it is? The problem is a lot of folks in the industry are having a go it alone instead of coming up with a combined industry perspective. So for it to be a salve scenario 3, we need to work together. So I would actually really say, take a look at these strategic questions and think about this, because I think we are moving in this direction. My opinion is we're going to get past that stop sign. I just really believe that. But then whether this will be another inequitable part of the overall healthcare system, or will this will be something that isn't an every man for itself, but actually a place where plans and providers work together to be able to do what's best for our members. I think it could be, but we've got to work together on that. Virtual care goes hand in hand with home care, and I have it split out because this one, I think the train has left the station in this one in many ways. I mean, telehealth is probably the biggest story of the pandemic. We saw utilization across specialties, just jump way up. And then look, overall, all specialty utilization came down. It's around 20%, but 20% more than zero. That's huge. What has stuck, where there's real stickiness is behavioral telepsychiatry. I mean, that's still there, and I think rightfully so, and importantly so. What the national conversation around telehealth, though, is not hearing enough of, is actually who is delivering this care virtually. There's been so much conversation around flashy new startups and private equity funded digital tools, and they're some of them are really great, but they're nowhere near owning the telehealth market. It's patients' own local providers who are largely owning telehealth delivery across all age groups. Just look at the slide there. So I think this market is the market's incumbents market to lose. I think the disruptors obviously get it. They're all looking at ways to move beyond just having a one-off visit with the patient to actually owning the entire relationship with the patient and getting paid for saving money across that spectrum. So the disruptors are out there. The plans are out there. Every day I hear about a new virtual first offering. They're leaning on vendors, which I think you need to be careful about, because that could disrupt relationships with your local providers. But this is the year, honestly, I think 2022 that we're going into, where we're going to see how successful are these virtual first options. Are you able to get the people who probably would use the virtual offering in the commercial space specifically? Are we going to see them doing it, and will it work? So watching it carefully, we come to two very different possibilities for telehealth future. For this and for for the sake of argument here, just assume that the amount of telehealth that we're doing right now, 20% of all care is going to be delivered virtually. It doesn't matter what number it is. It's going to be 1%, it could be 80%. But just assume it's 20% for the purposes of this. 20% of all care is going to be delivered virtually. The question is it 20% of everyone's care? Does every physician do a little of this, and every patient gets a little of virtual care throughout the year? I go in and get some things done, but I just do it virtually for primary care. I don't know. Or is it 100% of care delivered by virtual specialists, or maybe just for a targeted segment? Maybe those who need it the most, or more likely, maybe those who are willing to pay. This breaks the referral stream. It brings again another player in there who's not the existing hospital. So there's a race that's going on right now in digital health, but I don't think everyone knows that they're running the race. I mean, providers, they're the ones with the volumes and the relationships right now. It's theirs to lose, but for health plans, there's a race right now to set expectations. Set expectations on what telehealth really should be. Should you pay for it? Should it be for free? Is it in your benefits, or do I have to pick it? Is it something that you as a health plan are offering as a carrot to get your providers to participate in some sort of value-based arrangement? So future is open there in virtual care. Those are the questions I leave with you. Our next fork in the road is price transparency. We do a 2-hour thing just on price transparency. I'm going to be really, really brief here around price transparency. I think most of the public and press attention around price transparency has been all around consumer-directed care, meaning this new information is coming up to the public. Is it going to actually get patients and members to become true consumers? Will they shop around for higher quality and cheaper care, cheaper coverage? I think that's where the attention is. I know it's where the attention is. I think it's a distraction. I am not convinced that transparency is the rate-limiting factor on healthcare consumerism. I think it's highly dependent on whether consumers actually have the tools and time, and particularly the expertise, health literacy, to sift through all this data. I could spend a whole day unpacking this and what it would require for that to become a reality. But for the purposes of this conversation right now, I want to tell you, we at Advisory Board believe the most important implications of transparency are happening at the wholesale level. How incumbent players like health systems, plans, employers, and so on, how they're going to use this information to make strategic decisions around rate negotiations, around building COEs, so on. And the part of the industry I'm watching most closely are the vendors that are cropping up to serve employers. Employers are hungry for transparency, and there are a ton of vendors out there, and there are going to be a ton more that'll take this info, build an off-the-shelf solution for employers, and be able to give them the info that they need. So I think the big question right now is whether this is a new opportunity for vendors to set new standards for our industry. Look, one of the most active ventures in this space, Turquoise Health, they've already devised their own designation, which shows whether a hospital is compliant on their disclosures. Are we going to see more vendors that are going to write this story for us, or are we as an industry going to come together and maybe cooperate here and figure out what's appropriate for disclosures, what's appropriate information that we need to get out there? So 3 ways that I think transparency could end up. It either could be just a total distraction, nothing, or it could be because government or market forces move us to it. It could be something that is a true market disruptor that actually encourages competition on the basis of price. On the other hand, it could actually just enforce the existing market dynamics. We call that the market enforcer. It's just basically emboldening dominant players and dominant plans and providers that are already out there. Honestly, I wouldn't be shocked if maybe it's all 3 and if it's all very much geographically dependent. So we have a lot of information on the nuts and bolts around price transparency, but I wanted to give you the high level. The final topic, and intentionally I'm being outrageously brief, and it's health equity. And this is such an important topic that I feel the need to bring it up, but there's no way in an hour-long State of the Health Plan industry I could do justice for this. What I will say is the scenario here is that either will be a mission imperative or it's going to be an emerging business imperative. I think scenario 2 is where a lot of folks in the industry want to move it. Health plans, the challenge I give to you is creating that business case for health equity. It can be done. There's a lot that health plans are doing. This is an area that has the impact to greatly help lives, help your members, improve health and overall well-being of your members. But for it to be sustainable, we've got to have the funding, and it's got to be a business imperative. So we have another health equity presentation, same with price transparency, that we could spend a significant amount of time on. These are the questions. It's your world. What do you want the future to be? Now is the time. The decisions you're making will be impact what the next 3, 5, 10, 15 years are going to look like. If you found this helpful, we can bring the content to your teams. That email there, healthplan@advisory.com. If you want more information or have specific questions, we're doing upcoming research in the areas you see on the screen: Medicare Advantage and employer benefits, provider enablement. I've been enjoyed talking to you, and I see a lot of open questions in there, but unfortunately, I think these are things we'll have to take back and hopefully be able to get to you. If you didn't provide your email or anything, you can send it to the healthplan@advisory.com, and we will absolutely answer them. I will answer the one question about the prominence of specialty drug spend, high cost of these drugs. That is a major issue. That is the top issue that employers are talking to me within drug spend, and that's an issue that we're researching right now. I think getting a handle on that, and particularly the value-based contracting that plans are doing around that, is going to be the wave of the future. All right. I believe I can hand this back to the health team, because there's a fabulous and fun, and you can actually see her instead of just my witness protection blacked out face here, activity for you all. So I'm going to stop sharing my screen and hand you back to the team. Thank you so much for your time and attention.
Thank you, Ken, and to all of our attendees for joining us today. Please visit our website at health.com to catch up on all Health Go Live webinars, including this one, and join us at the inaugural VIVE event, the industry's new health information digital technology event, coming to Miami Beach, March 6th through 9th, 2022. And now, please welcome sommelier Sarah Tracy.
Hi, everyone. It's great to be here with everybody. And today I'm going to show you how to make 2 incredible delicious holiday cocktails. The first one is very sophisticated. It's a spirit-forward cocktail, so it's a little boozy, but it is a total showstopper that's actually pretty simple to make. And then I'm going to show you how to make a very delicious, refreshing, non-alcoholic cocktail, because we always want to have some of those on hand as well. So I'm very excited to do this with everybody, and we will be, I believe, making the recipes available if you want to grab them after the presentation and make these drinks for your own holiday guests. Hopefully we're able to gather together a little bit this year. So the first cocktail I'm going to show you is a twist on an old fashioned, and I'm calling it the Fireside Old Fashioned because it is a smoked cocktail. Sounds very fancy, but it's actually really simple. And the first step of this is to chill your glass. I have a glass that has been chilling in the freezer. And then we're going to smoke rinse our glass. So to do this, you're going to be lighting something on fire. You can use like a wood chip if you have some mesquite or apple wood chips hanging out from summer grilling season. You could even light cinnamon sticks on fire or herbs. I'm going to use just a tea bag. This is a cinnamon tea that we're going to light on fire. We're going to use this to actually smoke our glass before we pour the cocktail in there. So really fun to do and really simple. I'm going to just light up this tea bag, and I have a flame-proof plate that I have all ready to go. So when you light it, let's see, there we go. Just gonna start getting that guy going. Great. I'm gonna put it down on the plate and allow it to smoke. There we go. Awesome. Then I'm going to grab my glass from the freezer. And then I'm just going to turn the glass upside down and place it on top of that burning cinnamon tea. And it's going to trap the smoke. The smoke is actually going to stick to the inside of the glass. Because the glass has been chilled, it has a little condensation on it, which is going to actually help capture the delicious smoky aroma. So I'm going to set this aside, let it work its magic while we mix our cocktail. And an old fashioned is definitely one of my favorite cocktails. It is the classic cocktail of all time. And it's very simple because it only has 3 ingredients. So it's very hard to get it wrong. The first ingredient is always going to be a spirit of some kind. We generally see bourbon used in old fashioned, so that's what I'm working with today. But if you don't want to use bourbon, go for rye, go for other types of whiskeys. Even mezcal or aged rum can be pretty awesome in an old fashioned. So you don't have to let yourself be limited to bourbon if you want to try something different. But I'm going to go in with 2 ounces of bourbon here into a mixing glass. Again, a nice strong cocktail for us today. Second ingredient in old fashioned is always sugar or some kind of syrup. So I have a spiced honey syrup that I'm going to add 1/2 ounce to the shaker. And this is honey and water dissolved together in equal parts. And then you can add cinnamon, cloves, nutmeg, and just sort of let it all steep together and cool. And then you can strain it and you have a fabulous honey spice syrup, which is amazing in a wintertime cocktail like this. And finally, the third ingredient in an old fashioned are bitters. And I have a chocolate bitters here, which just, again, they smell and taste like pure chocolate. And I think with like the cinnamon, spiced honey syrup, a little bit of chocolate bitters, this is going to be really delicious, combined with the kind of that smoky character that we're going to have in our glass. So just 3 ingredient cocktail, that's all we're working with here. And I'm going to add just a small handful of ice cubes to my mixing glass. And we're going to take a spoon and you're going to stir it for about 15 seconds. We're not really trying to dilute the cocktail. We want it to stay really strong and boozy, but we just want to get it nice and cold. So that is why we are going to do this stir. Perfection. And now is the fun part. We're going to see how our glass is looking. Our smoke rinsed glass. And you guys can see, hopefully, the smoke wafting up out of the glass. It's so dramatic and it smells. It honestly smells like a fireplace with like a touch of cinnamon from the tea. And again, cinnamon sticks work really, really well for this too. And the smoke is all sort of sticking to the inside of the glass in terms of its aroma. And then I have a large spherical ice cube because I love working with cool ice molds. And if you use a large cube or a spherical cube, it's going to melt really, really slowly, and it's not going to water down your drink. You can get these at Home Goods, Target, Amazon. It's fun to have some different, style molds on hand. And now all we do is strain our bourbon, spice, honey syrup, and chocolate bitters mixture into our smoke rinsed glass over that beautiful spherical cube. And I'm going to add a little dehydrated orange to this as a really pretty garnish, but you could certainly use a fresh orange twist as well. And you have, again, a very sophisticated show-stopping cocktail. If your friends come over and you show them how you smoke rinse their glass, they will be talking about it for months. So really fun host party trick and not too difficult, but really fancy and fabulous. And this is absolutely incredible. The smokiness is subtle, but it's definitely there. And it just adds a nice, warm, wintry holiday twist to a great classic cocktail, the Old Fashioned. So that is our Fireside Old Fashioned. And if you're planning on making this, definitely drop something in the comments so we know about that. And then, assuming you will probably have some alcohol-free guests, pretty much people of any age love a festive cocktail, or people that aren't imbibing for whatever reason. I always like to make a fabulous alcohol-free cocktail because, there's only so much like cranberry and seltzer you can offer people before it starts to get a little boring. Like, I think even if you're not drinking spirits, you still deserve something really delicious and fun and different. So I'm calling this one the Yuletide Carol, and it is going to start, we're going to build it in a cocktail shaker this time. And I'm going to start with a whole ounce of fresh lime juice. And people do ask me a lot, how about bottled juice? And if you have a bottle of lime juice in your fridge that you want to use, absolutely. But I do think that fresh lime has such a bigger impact than bottled. And it is really easy to make. It takes like 2 seconds to juice a lime. So I like to use it fresh when I can. So whole ounce of lime juice, providing a nice tart, fresh base to this mocktail. And then I'm going to add half an ounce of rosemary infused syrup. And again, I love making my own syrups. If you have some like leftover herbs from cooking, you can toss them into a saucepan with equal parts sugar and water and heat it till everything dissolves. Remove it from heat, let it hang out for 30 minutes, and you're going to have a rosemary infused syrup. That is amazing. And then I'm going to add a half an ounce of a spiced cranberry syrup, bringing in a little more of holiday cheer. And finally, I'm going to add a drop of classic aromatic bitters, which are herbs and botanicals that have been then dissolved in a little bit of alcohol. So bitters do have a little alcohol, but we're only using like a drop. If you want it to be truly alcohol-free, you could absolutely omit this step. But for me, just a couple drops here. It's like the salt and pepper seasoning of your cocktail. It really lifts everything. It elevates the whole proceeding. It adds a lot of depth, which I think is really, really special. So lime, spiced cranberry, we have rosemary syrup, a little bitters, and finally, we're going to add some ice to the shaker and get a good shake on this. 20 seconds should be good, but until it's too cold to hold, that's kind of when you know you are think that's great. Ice shaking just kind of diluted the cocktail a little bit. It helps combine all those ingredients. And then I'm going to put fresh ice in a tall glass, and I'm going to strain our rosemary, cranberry, and lime mixture right in there. And then top it off with ginger beer, which is one of my favorite cocktail ingredients for any time of year, but especially for holiday. It's just so warm. It's like, feels like a little gingerbread. It's just lovely. To garnish and to finish it off, I love these festive holiday straws. You can get them at Party City or again on Amazon. This is a red one that has little snowflakes that makes it look really cute. And then I took a cocktail pick that had a little snowflake at the end of it, and I just studded some fresh cranberries on there. And I mean, talk about an alcohol-free cocktail that just looks so festive and every bit as delicious as a cocktail full of spirits. So definitely making spirits bright, pun absolutely intended with this Yuletide Carol cocktail. The lime, the ginger, the cranberry, the rosemary. This is just beautiful, and I definitely encourage you make this. You can make it in a big batch as a punch if you'd like, to make everything really easy on yourself in terms of your holiday hosting. A big pitcher, a punch bowl of this would be great. People could add gin or vodka to it if they wanted to. And then of course, the Fireside Old Fashioned. So I hope you got some holiday inspiration today. This was really fun being with all of you. And if you want to keep in touch with me, just pop over to Instagram, and I'm at The Lush Life on Insta. So come say hi. I'll be sharing a lot more holiday cocktail recipes and charcuterie board tips and wine recommendations and all sorts of great holiday content over there. So The Lush Life, again, on Instagram. Hopefully I'll see you all there, and thank you again for having me, and have a fabulous, happy holiday.